Raj, thank you. The only person who's not excited is Dr. Clark. So she knows exactly where that's coming from. How many residents here? All right. The rest are faculty. It's a hard topic. Kind of took it from big picture and towards the end of the lecture down to smaller picture of some of the physician business issues. Megan, do you remember what's it all about?
All about the money.
Next, all about the money.
Stupid.
Yeah, I'm stupid. But I always remember that, and I don't say that as a bad thing. You're trained in science and everything else, but if you don't have the resources to do your work, it isn't going to go anywhere. So I learned this, and that's why I went back to school. Disclosures, no relevant financial relationships. Some of my information, I did a fellowship at the AAMC. They gave me some of this information. The numbers have been changed to protect the innocent. So anybody listening, these aren't real numbers, close to it though. Residents, what's a good collection rate? I got money if you get the right answer. What's a good collection rate? 80%. 100%, 80% for what? What you build, what's that collection rate called? The point is, you gotta never assume. The whole point is, we talk about collection rates, we talk about a gross collection rate. If I charge you $1,000 and I get $100, what's my gross collection rate? 10%. If I'm supposed to get $100 off that charge and I get $100, what's my collection rate? 100. What's that called? My net collection rate. So the whole point is this. All the C-suite will talk in numbers. Ask. Never assume, because what's it do to you and me? What? Who's that? Kevin, you gave a great presentation. Thank you. I love the references. So again, if I charge $200, I contracted for $100, no copay. My allowable is $100, and I write off $100. So what's my gross collection rate there? What's my gross? I charge, 50%. What's my net? 100. So I want to make sure that I get, and I'm talking about the right things when I talk, because if you don't, people will notice that. And I always, when you go to get a job, my collection rate is da-da-da. My collection rate, just say, what are you talking about? Step back. All right. First, I have to, your former chair, Dr. Varghese, does he ever come?
He used to.
Oh, did he? Oh, he's getting old then.
Well, he's been playing a lot more tennis.
He's a mentor friend, and he's just an excellent all-around person. If you get a chance to work with him, work with him. And then, I shouldn't even give this lecture. Has everybody read this article? Has everybody read this article? Has everybody read this article? If you don't, this is a fantastic article. I don't even have to talk today. Raj, I use this all the time, so thank you. Did his residency at Harvard. Did you do your pain fellowship at Harvard? Mm-hmm. Okay. Why did I think Stanford? Did you work out there? Okay. He did his research in India. He's basically a rock star. I hope you know how big of a deal he is outside of this setting. Oftentimes in your own setting, you're nobody, because I know that, right, Megan? You go somewhere else and people think you're something. Dr. Mitra is something. So, Raj, thanks for all you do for our field. Okay, healthcare changes. You've heard about all this consolidation of health systems, changes in post-acute care. That's my love and specialty area. Value-based purchasing, narrow networks. So, this is the obligatory thing. Everybody complains. Healthcare, so much spending, right? Any of the residents have debt? Oh, only 3, 4? Okay, only a few of them. Do you think you should be paid well? What does the general public think? You overpaid doctors. We're spending too much money on health care. If you make 6 figures, what are you considered? Rich. Don't ever forget that. The general public looks at you like rich people spending a lot of money. But then, so if there's a lot of money spent, follow the money. What do we know? Health insurance groups, This was out of Modern. Anybody read Modern Healthcare? Simple throwaway journal. Okay, this is not, no disclosure, no interest in it. It's an easy one. A lot of interesting. United Healthcare, $156 billion. Is that a lot of money? Do those CEOs make a lot of money? Yes. So again, we're talking big business. Medicine isn't some little business. This is a big business. So reform. What happened with reform? They're talking about new payment models, value-based purchasing, alternative payment models. Of residents, name me 2 alternative payment models that they talk about. What? Come on, help me. Well, concierge, but that's not an alternative that CMS talks about. Fee for service, but they're doing some of the MIPS with that. That would be with value-based purchasing.
Like an affordable care organization?
Yes, an ACO is one of them. Oh, super. Baby Ruth, okay. I hate wearing a thing. All right, give me one more. Bundled payments. Are you involved with any bundled payment projects here? Okay.
We are as a healthcare system, but not the department.
Okay, we'll go over those because that's one of my favorite. It's almost episodic care payments is what I like to call it. And you can see some of the things, coordinated care coverage. Quick question, anybody on a readmission team? 2. Anybody care about readmissions? For years and years, readmissions came back. What did we call readmissions before readmission penalties? What? Bounce backs. What else? What did the hospital call them? Frequent flyers. What else they call them? Profit. Because there was no penalty for it. Was it a bad thing then? Yes, as far as morbidity to the patient. What happened? CMS came out with a readmission penalty. What happens now? We got teams all over the place looking at readmissions. 30-day readmissions. How many people that's ground into you now? Is that a bad thing? You're saying, no, it's not a bad thing. It's a good thing because we're taking the money and forcing us to try and improve our care, right? What makes changes in our behavior? My wife is one. That's the biggest driver. Second would be remuneration programs, right? Poor Dr. Clark is overworked, underpaid. But what drives her? Her altruism, right? Okay, this is recorded. There you go, Megan. Little love for you, all right. No, but okay, what's some of the drivers? Because when you have money, this is supposed to be a business, what's an opportunity cost? You're sitting here and lecture, what else could you be doing? Yeah, you could be sleeping, you could be at home, but why are you here? Is it to, okay. Yeah, beautiful. I know the real thing. Dr. Mitra keeps a roll, and if you're not here enough, you get in trouble, right? But no, that's one of the things. I went to my C-suite once. This is recorded. But now that there's readmission penalties, right, dollars amount, if you have $0 amount, are they going to put a lot of resources to it? I tend not to. But now if that resource penalty starts adding a bunch of zeros, are they going to start? Yes, come on, it's just what drives it's a resource. So we looked at our penalties here. Again, numbers are changed to protect the innocent. If you add a few more zeros, guess what they're going to start doing? Putting resources to it to improve the care. Is that any different than the production line for Toyota? What do? They want to fix the widgets and make them better and not have to do rework. What's a readmission? Rework. It's rework on a human being, right? So hopefully there is a bigger impact than just dollars. And there is. I'm being very sarcastic, but it's a rework issue. Simple, basic business principle. What else did they do? They started looking at overuse of codes. Don't think they look at everything we're doing and where the money is. What happened 2013 when any of you guys weren't born? This half. What happened to EMG codes? They slashed and burned them. Why? Because everybody and their sister was doing 4 extremity EMGs. Everybody and their sister was doing, they got tarsal tunnel, let's do a blink reflex. Oh, let's do, no, I'm being sarcastic, but they call them, what do they call them? Misvalued codes. So if I'm doing a lot of needle injections, axial injections, what might happen there? How do they change behavior? Change remuneration, right? This is just the way it is. You got to be aware of it because you're going to be out in practice. If you do what's right by the patient, you're going to be fine. This is also, that's my favorite author. You know, what are you laughing about? It is. He's a good guy. We looked at when we moved our ICD codes. Oh, I'm not very good. I'm sorry. Up here. When we changed ICD to ICD-9, what's ICD stand for? Oh, that's a whole nother lecture. I could go down to the details. International Classification, Disease or Diagnosis. I can't even remember now. But we went from 9 to 10, right? What happened? That impacts small, medium, and large, 100 up to 2.7 million. Why? You have to retrain your coders. You have to put in new systems. So whenever there's a change, it takes work and effort and time. And time is what? Money. Or a happy wife, or a happy husband, or a happy significant other, right? Partner, I should say. So what did they say? They said, look, we're going to do an ACO. What do they do with ACOs? We're going to pay you money to take care of patients, right? And if you save money, who gets the money? The ACO does. So what happens now? In fee-for-service, a provider is on the income side. Good. I do more, I make more, right? Start going to ACO, payment to providers are what? Now an expense. So know what your system is. Right now I'm living on fee-for-service. How are you guys?
Living on fee-for-service?
Yeah.
No, we've got a different model.
Yeah.
Work RV model.
Yeah, different model. I guarantee you, you go out and, who's a fourth year?
But pre-integration we work.
Yeah. Fourth year, where are you going to work? Here? Why do you say that laughing? Congratulations. Congratulations. Oh, is he repeating a year? He's repeating it? Okay, I just didn't know. That's fine. Just learn more. Dr. Mitra is a great chair to work for 5-6 years. The other thing, now we're going to talk about bundled payment. This is another big picture. What is a bundled payment? I call it episodic care. You got a diagnosis. You come in. Time period, it used to be 90. Some of them are 60 days. This is Medicare. We're going to pay you what you normally make. At the end, we're going to take all, say, with total hips, the cost on average. And if you beat a set price, we could go in again, that's a whole nother lecture. If you beat that price, you get a reward. If you're way over that price, what happens? You pay back some money. So guess what? People start looking at the expenditures. Again, this is just some financial modeling, and you can have different models of it. But it's, just think of it, all costs, physician costs, x-ray costs, hospital costs, post-acute costs, going to that expensive IRF cost, going to the SNF. And what you do is there's a bunch of different diagnoses that you could participate in. I had access to some of this. And big point of the whole lecture, green good or bad? Green is good. Red good or bad? Bad. Good. Green good? Yeah. Red bad? Very good. Dr. Clark knows my, yeah. All right. But again, think of it, okay, when you look. So, spinal fusion, non-cervical, 38 patients, they lost some money there. Total joints, major joint replacement. Wow, they made 1.2 million. Why did people choose joints? Why would a lot of people choose total joints to put at a 90-day risk for money versus CHF? You're physicians now. You're actually trained clinicians. You're a clinician. Why is a joint easier to take care of than cardiac failure? What? Yeah, you've already gotten something and you did a great job, did I tell you? It's more predictable. It's a elective procedure, right? And I'm not going to operate on someone who has a lot of medical problems acutely. I'm going to get them going, give them prehab, get them strong, then operate, and I'm going to have less out problems. What's CHF? They got COPD, they got big old ulcers all over the place that come in, and they got bad disease, right? They have an unpredictable course. You have a small number and they have a high expense, you're toast, right? So that was one of them. We looked at some of the inpatient care was in blue costs for 90 days. Red was post-acute. That is after they left the hospital. What do you notice? A lot of money spent post-acute. How many people here know where your patient goes after they leave here? How many people control what happens to them once they leave here? How many people like shooting in the dark? Yeah, my wife does that. Go run, Greg. Boom, boom. If I hit you. No, but on a serious note, that's what we're doing financially, aren't we, if we're not controlling where people go? Who knows post-acute better than anybody? I knew. Where'd you go train? Yeah. All right. So if you look at it, we looked at this. Cost drivers. Each of these bars is a patient on the x-axis. On the y is cost. Well, when they started getting readmitted, these are, if you'll notice this, it's pretty level for the joints, right? There's a few people who are going to have come back, be sick, infected, right? Now look at CHF. Boy, what a variation. The red is what? A readmission. Readmission's good or bad?
Very bad.
Bad. Very bad. Now you're getting dinged on a readmission penalty, and you're getting dinged on the cost if you join that bundle, because who's responsible for that cost? The hospital, the ACO, or whatever group took that on. So I want to avoid readmissions, right? If I know where they're going, I might have a better chance of controlling their care. If I don't know where they're going, what happens? I'm doing what? Beautiful, educable. I'm going to hit somebody one day. All right, so why does this make me happy? Because before that, we didn't know what patients did. Now what happens, we care about what happens to people afterwards, right? Who's the best at knowing where people should go, what they do? Come on. All right, thank you. PMR, right? Because one thing we helps now with medicine, and I like this, we shouldn't discharge. What's a discharge? To relieve of a burden or contents, to unload or empty, to release from confinement or duty, right? To dismiss. He's not dismissing. You're here for another 2 years. Transition is to change from one state condition or another. So should we discharge patients? No, we should transition them to home, to IRFs, to SNFs, to whatever. And this is your money in the future. If you don't have a loan, don't listen, right? Because if I don't bring something of value to a system, are they going to pay me? No. Is Dr. Mitra going to pay Dr. Clark if she doesn't provide some value? By the way you're getting paid, I don't know. No, at least John's out working right now, right? Okay. So we did this at our place, and you have a level, what used to be a Model 3, where they started at Post-Acute. This was coming to our IRF and strokes. We made money. How did we make money? What was one of the key elements we did? You can control what you do in the IRF, right? But how is IRF paid? By day or a global payment? A PPS payment, almost like a DRG. You guys know, but how? What? What? Right, it's a bundled payment. So can I make money by discharging them earlier? Yeah, how? Well, then the facility makes it, but now if I own a bundled payment, if someone's discharged earlier, does the bundle make more money?
It's the same amount.
Right, I pay the same amount for that patient, right? So what did we do here? We're not going to control the payment to the IRF. We're going to control after the IRF. All we did was hire a care coordinator, call the patients, get their meds, do the things, be kind of mom to the patient. You don't have your warfarin, let me get it to you. You don't have your appointment, let me call and make it for you. Kind of simple stuff. And if you look at it, this was Dobson and Davanzo. Greater than 8,800 different significant variations after someone leaves, right? The count of unique post-acute after discharge for all things. The first setting after discharge from acute care hospital is the major driver. If I walk upstairs right now, who decides where people go? Who decides upstairs discharge right now? The attending? Insurance? The case manager? The intern just wanting to get another patient off their service? I could say all of the above. So you're shooting again in the wind. We got a shotgun and it's going all over who goes where. This is our opportunity as PM&R docs. Because who looks at the social situation? Anybody here? Do you guys ask what's the home situation? A little louder. Yes, I was on rounds yesterday and I asked the cardiology resident, so where do they live? They had no clue. Who do they live with? Got no clue. Does that impact whether they come back? Yes. So one of the things we have done, who controls what happens in the SNFs?
Rehab docs.
Do they? Do our rehab docs go here? Do we have them go into the SNFs? Sometimes. We don't have it either, but we want to. But we developed a care network where we have certain SNFs, and to join our care network and the patients get this flyer, what do they got to do? Report their readmits, report if they're following our protocols, all the things that way. And guess what? Then they get to be in the flyer we hand a patient. Can't tell a patient where to go, can we? Yeah, bullshit. I didn't. Darn, no. I mean, but you can say, wow, we do have docs that go here. We do know what their readmit rates are. We do meet with them on a monthly basis to work on improvement. What do you think the patient's going to choose? Come on. How many patients have any clue what goes on out here? How many docs in the hospital have a clue what a SNF is? SNF, rehab, what?
It's funny because it's not very many.
No. Who knows? We do. He's trying not to do next year. 6 months, and we're down to 6 months now. All right, so post-acute care, a lot of money in it. Kane in the archive said recovery, recuperation, rehab. I'm saying today, it's a lot more medical management out there, a lot more service-driven, and it's changed. So what do we have to do? Who said it? Yeah, you're like the star, aren't you?
No, I'm really not.
What year are you?
Third year.
Third, you want to transfer? We might have a spot. Wait a minute, at least she's talking. What do you think, Megan? Should I still? She must be on your service then. You'd have to do work. Okay, what did Institute of Medicine say about post-acute? We should do, if there was no variation in post-acute care, the total variation in Medicare spending would drop by 73%. Variation. Who does clinical guidelines here upstairs? Who follows clinical guidelines? I hope we all do. And what do we do whether someone should be anticoagulated or not? There's a guideline, right? There's still a variation, some fall out, right? Is the variation 73% on DVT prophylaxis? I hope not. I hope not, right? So what do we want to do with variation? Bring it down, change the variation, and then we can control things. Right now, no one's controlling anything. So they said providers should integrate care delivery, good or bad. I'm getting white-haired. I like that. Coordinate care, share data, and health outcomes. Does that make us better? Yes, I sure hope so. So these are not bad things. How would we drive that to happen?
Money.
Yeah, money,
Time.
money.
Time.
Yeah, thank you. God, yeah, the minute you forget about it, we're stupid. No, I'm serious. Don't be stupid. It's part of the whole picture. And so if you want to learn more about this, MedPAC, advisory board to Congress, anybody ever looked at these books? They're online, they're free, medpac.gov. There's a whole section on post-acute care. There's a whole section on physician payment. The best data, I steal so many slides from their information. And here's one of them. So if we then look at facility margins, and if you look at IRFs, for-profit IRFs, what's their margin? 23%. Would you take that as an investment? Well, now the way the market's going, maybe not now, but usually would you take that? Yes. Whose money is that? So this is Medicare. Whose money is that? Where does Medicare get its money? Taxes, yeah. Who pays taxes? I hope you pay them. If you don't, keep your mouth shut, okay? No, that's our money, right? Is 23% of margin what you would expect someone to get? They're looking for money. Where do you go? Follow the money. Stupid. So SNFs 11.2 overall, home health 15. So what are they going to do with that? They're going to change payment reform, right? Who's that going to impact? Us and our patients, because things may or may not be available. And again, is there money in post-acute? Yes, you wouldn't have these for-profits. Select, Genesis, Brookdale, Encompass. I have a joint venture with Encompass. Their net revenue in millions. In 2018, $4.2 billion. That's small potatoes. Mitra will pay you that when you graduate. But no, so there is money there, because would people be doing it if there weren't? No. So there's opportunity there, but be aware of the things. And then MedPAC said this is right out of MedPAC, a letter to Congress. It says, IRF margins, which have been above 11% since the Commission determined that Medicare's current payment rates for IRFs appear to be more than adequate. What does that mean? Down. Okay. And therefore that Congress reduce IRF payment by 5%. What would happen if they reduced the IRF payment by 5%? Who would go nuts? The C-suite would. Dr. Mitra would. Because what would then they do to Dr. Mitra? Raj, why aren't you making us the money? It's not a good or bad thing. It's what it is. Okay? So you need to be aware, because that's going to help dictate policy and things. Now, will this happen? I don't know, but that's what they're recommending. And then they're changing payment. IRFs, anybody remember FIM? Yeah, and then they messed this up. What are we using now? Who's on the IRF service? Not beautiful. What are we using now for measurement? So FIMS, but we're doing the GG model for measuring, right? We're going to go to GG codes. Okay, and it's going to impact payment. We change from FIM to GG. We change from ICD-9 to ICD-10. What does that do? Costs you money, right? Because you got to train everybody. You got to do it. These are not small things. SNFs used to be paid off of what? Resource utilization groups. Anybody know what that is? RUGs. And how did you get your higher resource utilization group? A lot more therapy. Lot more therapy, right? They just changed the SNF payment where they're going to pay more for extensive, intense therapy that is going to be more skilled nursing driven, less therapy driven. Will that impact what we can do with patients in SNFs? Yes. Home health, who's ever signed a home health form? Who's ever gone, another home health form? 60 days episodes, they're going to go to 30-day episodes. Who's going to go, It means more forms to sign, more effort, more energy, more work. These are already happened, okay? So that's going to impact us because time is what? Money. So it is critical that hospitals are now interested in post-acute care. Raj, have they come to you, the hospital, and said, what goes on out there?
Sometimes.
Yes. I've been stomping for 15 years, and guess what, Megan? They finally have us on the top 8 of the health system, post-acute care. Why? Why are we finally, because I've been preaching this for years. Readmission. Oh, I love you. I don't know who you are, but you finally talked. Why else? Why are they finally listening?
Money.
The money what? Yeah, there you go. Yeah, it's the money super. Good case. No. So it's put us on there. And now, docs are smart. Physiatrists roll in skilled nursing facilities. There's big companies out there now where physiatrists are going. U.S. Physi Integrate, these are not, I don't work for either of them, but they're hiring docs, putting them in SNFs. Why? Well, we used to put a lot more people in SNFs than rehab, right? And these entrepreneurs or docs are smart, or there's a need for our services there. Why? To coordinate the care. I'll be interested to see what happens now that they've changed payment models. All right, 10 minutes. You're killing me, Smalls. And it's killing me. So here's a question. We did a survey of chairs and said, do residents rotate in SNFs? For them, of the 31 that didn't have them, 29 said we should. Do you guys rotate? Okay. Why? My guys don't rotate. Why?
Our hospital's not affiliated.
Now, why don't we rotate? Why? What's the answer to a why question? Money, stupid. Because we're paid by Medicare, and Medicare or the hospital say, I want you here. Now, I'm in a group looking at this. If you have a doc supervising 5 days a week and you go somewhere, you can get paid, even at a SNF, for the resident work or things. So there's maybe opportunities. So why don't we send residents there? We're not getting paid for them, right? We have to pay you guys. Sometimes 5 years instead of 3. Yeah. I can't believe that. I will say no more. I did have to put John first, A, B, C. Okay, all right. What do I hate? I hate change. I've been there 17 years. They can't get rid of me. But I hate change. So in your things, understand, everybody know Dunabedian model? Remember the structure. Know what the system you're in. What happens with the process or outcome. I know what the outcome is for most of the C-suite. What do they want? Good care and money. So now I have to figure out what's the structure I'm working in and how do I adjust processes to get that. Now I can really cuss. Because same thing at my hospital. They're going to pay me for certain things. I want to know what they're focusing on because I need to pay my residents, pay my docs. I'm going to zip through. One of the biggest things is we looked at length of stay opportunities. Just by cutting length of stay 2/3 of a day, we'd save this much money, $150K in stroke. We have a bad length of stay problem. Did anybody know? You're killing me, Smalls. When we say average length of stay, it's not really an average. They're measuring the median, not the mean. Did you know that? I didn't either till like 2 days ago. I was like, so average length of stay, do you do it by midnight, by hours? And they say it's a median. There's a big difference, right? You do a scatter plot, a median versus an average is different, right? So what do we know with length of stay? Who knows about early mobility? Who knows about medical, functional, social, financial, geographic choice? Those are the factors that get people out. You do. Is there value in the acute hospital? Don't sell it short. How many people go, I can't cuss here, but beep, 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 beep. All they want is disposition. I'm here just to say where someone can go. How many residents have cussed about that on a consult? I'm just a dispo. I have. I've heard it every day. Dr. Clark used to. There's value in that. You put them in the right spot, they don't come back. Also, they're paying me for that. Don't undersell that. Oh, elasticity, I don't have much time. That means if I cut prices a little, I'll get a lot more patients in. What did we do at our university? We did that. Just like the spine clinic that Dr. Mitra runs. Now we got inundated with spine patients. What did we do? If you come into PM&R, do they all go to surgery? I hope not. And so if the system is at risk for the cost of those patients, do they want a lot of surgery? No. If they're not at risk, do they want a lot of surgery? Yes. Oh, I didn't say that. It's a financial issue. So we did the same thing. Looked at all our providers. The surgical referrals were 8.7% out of this 4,000. 6% were surgical candidates. If I'm a surgeon and I see patients that are all surgical candidates, am I happy? Yes. Who gets paid more, PM&R or surgeon? So if I run the system, do I want my surgeons to be efficient seeing more surgical candidates? Yes. They did, even on those candidates, people still refuse surgery, but we have a very high yield of surgery, right? For the small number they see, do patients like going to see a surgeon to hear, no, get out of here, you dumb, yeah. No. They'd rather come see us in PM&R. Let's do some therapy. What's the injection? Should we do nothing? Here's a game plan. Hugely successful. So our narrow network, we even looked at costs. Biggest cost for our patients? Physical therapy, no biggie, because you look at it, imaging, surgery, chiropractic care, and injections. Those were the top costs. Now, why is physical therapy? Remember, 4,000 patients, not a lot going to surgery clinic. We're utilizing therapy a lot more. What's our next step to look at then? Our next step is, again, numbers made up, but our therapy sessions, if you have more than 5 therapy sessions or more than 10, you're going to add up. There were some therapy set 23 times going to physical therapy. Someone's got to say, time out. Are we doing any good? Chiropractic care, that one chiropractic 35 times. Do I want that? I'm a PM&R doctor. That's a lot, isn't it? Let's maybe look at that. So now we're actually looking, and our group is looking with our own therapists. Can we go from X to 2 less therapies, still get the same results, right? Now you're knocking off 2 therapies, a lot of money, not a ton, but if you have a high volume of patients, a little bit adds up very quickly. And these are the ones, remember we talked about ACO and providers, you're now an expense. We did something looking at patients going out for appointments. We dropped our outside physician appointments. I live in a freestanding hospital. They have to put the patient in an ambulance or transport and go over. We saved 100 trips. Each trip costs $300. 100 times 300 adds up. What does that equal? An extra nurse, an extra something. If I'm in that group, do they then like me? They don't like me. Megan can tell you that. But at least it gives me, hey, now we have saved you. We're working with you. Do I bring value? Yeah, it's some money, stupid. We did the same thing with fees and barium swallows, cutting down our barium. He just came and talked to us. Outcomes equal income. If you get better outcomes and you can help drive them, you now have things you can push for. This was the student debt. I'm hustling because we got 3 minutes. MIPS and MACRA. Have you heard about that, residents? Okay, this is an adjustment on value. If I'm in an alternative payment model, a bundled payment, I'm going to get increase on my physician charges. With my MIPS now, I have to report quality metrics that are going to either bump my payment up or drop it. Where I work in a big practice, good for me, because they do the scoring and quality off my family medicine group and some of the simple things, and I get credit for it. If you're going out into a small practice, you need to read up on it. Don't have the time to do it, that's a whole nother lecture. Residents, there's quality metrics, cost improvement, and interoperability. There's a whole group of things, and it's a percentage of the payment. This was more for this side of the room. What do we get paid on? What do we get paid on? Here it's RVUs. What generates an RVU? Seeing patients. Is that what we get the RVU on, seeing patient? No, it's what?
Productivity.
Productivity, no, it's what? How do we determine productivity? Your note. It's what you put down, right? I don't care what you did, it's what you wrote. You better write what you did and find out the way you write what you did, right? This is a whole nother lecture. If we had another hour, I'd do this with the residents. I see a patient, I give a service. I document that service. That documentation goes with a CPT code, Common Procedural Terminology Code, right? That CPT generates an RVU assignment. That RVU is often then translated into a payment. And what do I use it for? Anybody going out to practice this year? We only got one. So what do we, right now, Megan, what are you paid on for your clinical service? RVUs. And how many RVUs did Dr. Clark see? Who's with Dr. Clark? Anybody? Oh, they still let you have residents? I thought you were on probation. How many RVUs did she produce last week? But, okay, we often use metrics. MGMA and Faculty Practice Solution might say, wow, to be in the 50th percentile, you've got to generate 4,000 RVUs. How much work is that? A lot? A little? My recommendation, a lot more people are using RVUs, and if you don't know how much work that is, how can you sign a contract? We're working on some education programs with our residents now, sorry Megan, on, hey, how much RVUs did you generate last week? Because if I don't know, Roger's smart. He can go, nah, you got to do 10,000 RVUs, and I'm being light on you. But how much work is that? So how can you do that? I use it all the time to look for employment. I use MGMA targets or Faculty Practice Solution targets. So I would recommend get familiar with them. Because I have to even at one point had to do, this is the percentile of work someone did and patient satisfaction. I did a plot. These people, a lot of work, happy patients. These people, not much work, not happy patients. What was one of these? Work comp, you don't get RVUs assigned, you get what? Charges, cash. It's a whole different ball game. So know what ball game you're in. But this is something I have to use and do with my C-suite for each doc. And then what else do we do is we look at Faculty Practice Solution as just a benchmark to say, wow, for initial hospital visits, red is the national average, blue was this provider. And what do I look at? Is it right or left shifted? He looked about on, or she did. New office visit, this is blue, this is national. What does that tell me? Resident, your analytics.
You're seeing less level fours.
Yeah, you're seeing or you're documenting. Yes, documentation. This is not off seeing, this is off documentation, remember. These are your CPT codes. They're determined by what I do and document, right? So the question here is, maybe I'm seeing less patients sicker, I'm not doing as much. You know, if I was over here, My blue line, what would that tell me? It's not sicker, it's what I'm documenting, okay, and what I'm doing. You always want to make sure, document what you do. Don't do so you can document more, right? Give the patient what they need and let the chips fall where they may, but be educated on what you need to document. This happened with me because, trust me, I'm Dr. Worsowicz, trust me, we're watching. I work with a big system, trust me, watch me. These are my work RVUs per visit, and they dropped. These are my visits. No, these are my work RVUs, I apologize, and these are number of visits. What happened? We don't code our own, we use coders. How do you do here, Raj? Do y'all use coders?
No, we do our own coding.
Yeah.
Code the bill.
Oh, good. We abstract code. They changed the policy on medical necessity. I took it in the shorts. You know, my docs did, my department. I had to go to them. We had a big education session again. It was simple things. I didn't disagree with them, but it cost us, we were up in the 6 figures on collections. Who does that hurt? Me. So you need to monitor what you're doing, because Megan, watch out if they try and undercut you on your, No, but on a serious note, you want to always look back. What are you doing? How am I coding? What happened? This was a policy change that impacted my department. And this is just contracts. This was when I was doing, this was our average dollar per contract, made up. But that was the average dollar per RVU for the whole place. This was 2012. Do you want to be average dollar per RVU here or here? I want up. Who determines this versus this? I want to know who's making the policy. Where do I fall on that graph? Here, you're not so much your dollar per RVU. It's a little bit different ball game. Because if I'm going to practice and I'm paid off of cash, which contract do I want? A, B, or C? B. Yeah, heck yeah. I want to see a lot of B patients, right? But what's the advantage of getting paid $1 per RVU? Straight. It's all about what? Come on, guys. Help me out. You don't have to worry about if it's C, B, or A contract, right? Because you're getting the same amount. So you're getting rewarded for your payment of seeing a patient, regardless of payer mix, right? If I'm paid off of cash, I'm fighting for these and put these in Dr. Clark's clinic, right? She's nice, she's altruistic. So be aware, you just have to know what's going on. And there's all sorts of things. This was out of modern healthcare compensation. You know what field was not there? PM&R. Why? Because we're a tiny, tiny field compared to a lot of these big ones. So be careful when you look at metrics and numbers. You want to look at the end value. If you use MGMA, Faculty Practice Solution, the Academy, AAPM&R, AAMC, when it says PM&R, what's the end? Because if it's small, what does that do me if I'm negotiating? If I like the numbers, I should keep my mouth shut. If I don't like the numbers, what do I do? That's a small N, yeah, or go to another one. I like this one, but you go, that's a small N, that's not, reasonable, that's, not there. So this is the end, I'm almost there. Right now we were on a fee-for-service, didn't matter any quality, there was no readmission penalty, there was no MIPS, there was no MACRA. When I grew up, what was the big thing? I just saw a lot more patients. I was paid per due. I get paid. Boom. It's kind of like, I won't go there. Megan, I don't know this group. I got to be careful. All right. What are we doing now? We're starting to get paid for value. We're starting to do bundled care. There's all sorts of mix of it, right? What did we know from ICD 9 to 10? It costs money to change big systems, right? So every big system is going, I like fee-for-service, I like it, I'm not going to change yet. But we're going to have to change. Everybody predicts. And if you wait too long to change, what will happen? The valley of death, boom. if you jump too early, what'll happen? It's a lot farther jump. And what happened to Evel Knievel when he jumped? Did anybody here even know Evel Knievel? Yeah, well, all right. What happened when he did the Snake River? Right? He tried to jump too far too early. This is where we're kind of sitting in things. And who knows what's going to happen in the future. And for the guy in the back, this is happiness. You can wake him up back there. And I'm done. We went through a ton of things. Each area there could have been a whole thing, lecture. Megan knows I like to talk a lot more than anybody else in this room. In fact, she used to walk in the consult room. I'd just be talking, walking back and forth. She goes, "Who are you talking to?" Me. I owe a big thanks, Raj. Thanks for letting me come. Anna, thank you very much for all your help with everything. Because if anybody knows who runs the show, Anna. It's not this guy. So thank you very much.